A guide to choosing affordable private health insurance. Securing affordable private health insurance requires a two-pronged strategy: choosing the right marketplace and proactively managing both premium and out-of-pocket expenses. This must be done while navigating the difference between comprehensive, ACA-compliant coverage and non-ACA-compliant limited benefit or supplemental plans. Additionally, understanding enrollment timelines, alternative options like Medicaid, and key financial thresholds, such as federal poverty level guidelines, is essential for making informed decisions. This guide, updated as of October 7, 2025, incorporates recent regulatory changes, state-specific resources, emerging trends like telehealth, and interactions with programs such as Medicare. Part 1: Where to shop for comprehensive coverage. The choice of where to purchase health coverage is critical in determining eligibility for financial assistance, which directly lowers the cost of insurance. Before shopping, note that ACA marketplace enrollment is time-sensitive. Enrollment periods. Open enrollment period. For coverage effective January 1, 2026, the open enrollment period runs from November 1, 2025, to January 15, 2026, in most states. During this time, anyone can enroll in or change marketplace plans without a qualifying event. Some state-run exchanges may have extended deadlines, e.g., January 31, 2026, in states like California, so check healthcare.gov or your state's marketplace for specifics. 16, 17, 18. Special enrollment periods. SEPs outside of open enrollment. You may qualify for an SEP due to life events like losing other coverage, marriage, having a baby, or moving. SEPs typically last 60 days from the qualifying event, allowing enrollment in marketplace plans. 16, 17. The Health Insurance Marketplace. On exchange, the Federal Health Insurance Marketplace, healthcare.gov, and its state-run counterparts are the sole venues for obtaining federal financial assistance under the Affordable Care Act, ACA, for state-run marketplaces, such as Covered California, coveredca.com, or New York State of Health, newyorkstatofhealth.ny.gov, may offer additional subsidies or unique plan options. For example, California provides state-funded premium subsidies for incomes up to 600% FPL, 18. Premium tax credits, PTCs/subsidies. The core benefit of shopping on the marketplace is the PTC, which reduces monthly premiums based on household income, using modified adjusted gross income, MAGI, relative to the 2025 federal poverty level, FPL, for 7. The Advance Premium Tax Credit, APTC, is paid directly to your insurer to lower your monthly bill, with the final PTC amount reconciled when filing federal income taxes. If your income exceeds estimates, you may need to repay some or all of the APTC. Report income changes to the marketplace promptly to adjust subsidies. 4. The 400% FPL threshold for PTC eligibility is temporarily eliminated through 2025 by the Inflation Reduction Act, allowing higher-income households to qualify. 6, 17. As of October 2025, Congress has not extended these enhancements beyond December 31, 2025, potentially leading to premiums more than doubling for many enrollees in 2026 without further legislative action. 6. Monitor cms.gov or congress.gov for updates on potential extensions. Use the KFF Subsidy Calculator, kff.org/interactive/subsidy-calculator, or healthcare.gov's plan comparison tool to estimate savings and compare options side by side. 7, 19. The 2025 FPL guidelines for the 48 contiguous states/D.C. are household size 100% FPL 138% FPL Medicaid expansion threshold 400% FPL historical upper limit 1. $15,060 $20,783. $60,240. 2. $20,440. $28,207. $81,760. 3. $25,820. $35,632. $103,280. 4. $31,200. $43,056. $124,800. Add $5,380 for each additional person. Alaska/Hawaii have higher thresholds. Cost-sharing reductions, CSRs. Individuals who qualify for PTCs and have incomes between 100% and 250% of the FPL may be eligible for CSRs, often called extra savings, or discounts, which lower out-of-pocket costs, e.g., deductibles, copayments, co-insurance. 4. To receive CSRs, enrollees must select a silver tier plan on the marketplace. 4. 7. Catastrophic plans, available on the marketplace for individuals under 30 or those with a hardship/affordability exemption. These ACA-compliant plans offer low premiums, high deductibles, and coverage for essential health benefits, EHBs, plus 3 primary care visits per year before the deductible. They are ideal for young, healthy individuals ineligible for subsidies. 16. For free assistance, contact marketplace navigators or certified enrollment counselors via healthcare.gov or your state exchange. They can help with applications and plan selection without cost. Basic Health Program, BHP, authorized under Section 1331 of the ACA. The Basic Health Program, BHP, allows states to offer affordable, comprehensive coverage for low-income individuals above Medicaid eligibility but eligible for marketplace subsidies, typically those with incomes between 138% and 200% FPL, e.g., $20,783 to $30,120 for a single person in 2025, 55, 56. States contract directly with insurers to provide standard health plans that mirror ACA-compliant marketplace plans but with lower premiums and cost sharing. In 2025, BHP operates in New York, Essential Plan, 1.5M enrollees, Minnesota, Minnesota Care, 98,000, Oregon, new in 2025, and Washington, D.C., Healthy D.C. Plan, Blueprint approved, 57, 58. Funding and affordability, funded by 95% of the federal PTCs and CSRs enrollees would receive on the marketplace. BHP plans often have higher actuarial value, 85 to 90% versus Silver's 70%, with premiums as low as $0, e.g., New York, and copays capped, e.g., $20 in Minnesota, 55, 56. States can reinvest savings to enhance benefits, like dental/vision in New York. Eligibility and enrollment, open to U.S. citizens or lawfully present non-citizens ineligible for Medicaid, with year-round enrollment, no open enrollment required. Income thresholds vary slightly by state, e.g., Minnesota includes some below 138% FPL, 57. In Oregon, the OHP Bridge program, launched July 2024, covers adults aged 19 to 64 with incomes 138 to 200% FPL, including medical, dental, and behavioral health benefits with no premiums or out-of-pocket costs for many. Enroll via OregonHealthcare.gov or by calling 1-800-699-9075, 57. In Washington, D.C., the Healthy D.C. Plan, new for 2025, targets 25,000 residents losing Medicaid eligibility starting January 2025, offering no premiums or out-of-pocket costs for doctor visits, urgent care, hospital stays, and prescriptions. Check dchealthlink.com/healthydcplan. Or attend community meetings for enrollment details, with implementation tied to restructuring of the DC Healthcare Alliance, suspending new adult enrollments from October 1, 2025, 58. Benefits: covers all 10 EHBs, e.g., maternity, mental health, prescriptions, with state flexibility to reduce cost sharing or expand provider networks. Pros: lower costs than marketplace plans, seamless transitions from Medicaid, and high coverage value. Cons: limited to select states, may exclude children in some programs, and funding depends on federal subsidy benchmarks, 56, 58. Check state health departments, e.g., New York State of Health at newyorkstatofhealth.ny.gov, or medicaid.gov for eligibility and updates, 55, 57. Buying directly from an insurer. Off-exchange, individuals may purchase health insurance plans directly from an insurance carrier or a third-party broker, often referred to as off-exchange plans, 14. These plans fall into two main categories: ACA-compliant qualified health plans, QHPs, and non-ACA-compliant plans, such as traditional indemnity or fee-for-service plans. Understanding the distinction is critical to avoid inadequate coverage. ACA-compliant off-exchange QHPs, these plans mirror those sold on the health insurance marketplace, covering all 10 essential health benefits, EHBs, and meeting minimum essential coverage, MEC, standards, but they are purchased directly from insurers or brokers. The major drawback is the inability to use premium tax credits, PTCs, or cost-sharing reductions, CSRs, 14. These plans are best suited for individuals or families whose income levels make them ineligible for federal subsidies, e.g., above 400% FPL if the Inflation Reduction Act extension expires in 2025, 14. Non-ACA compliant plans, e.g., indemnity/fee-for-service plans. Traditional indemnity, or fee-for-service, plans allow enrollees to visit any provider without network restrictions, reimbursing a percentage, e.g., 80%, of usual and customary fees after meeting a deductible, 39, 40. These plans emphasize flexibility, making them ideal for rural residents or those seeking specialists outside typical networks. In 2025, they are less common, under 5% of the market, and are typically not ACA compliant unless explicitly designed to cover all 10 EHBs without annual or lifetime limits, which is rare. Premiums range from $800 to $1,500 per month for individuals. Pros: broad provider choice, no referrals. Cons: high premiums, administrative burden, filing claims, potential for balance billing, and limited coverage if not ACA compliant, 41. Always verify ACA compliance with insurers or brokers like eHealth to ensure the plan meets MEC standards, as non-compliant plans may leave significant coverage gaps, 39, 40, 41. Private health exchanges. Private health insurance exchanges, operated by brokers or insurers, offer ACA-compliant plans and sometimes supplemental coverage, 11. These platforms may provide more plan variety or enrollment flexibility than the public marketplace but do not offer PTCs or CSRs. Verify ACA compliance before enrolling, as some plans may have limited benefits, 11. Association health plans, AHPs. AHPs allow small businesses, self-employed individuals, or professional groups to pool together to purchase group health insurance, potentially lowering costs, 3. Some AHPs are ACA compliant, covering all EHBs, while others may exclude key benefits. Availability and regulations vary by state, so check plan details and state insurance rules to ensure adequate coverage, 3. For state-specific AHP info, visit your state's insurance department website, e.g., insurance.ca.gov for California. Employer-sponsored insurance, ESI, offered by employers. ESI is a common private insurance option, covering about 180 million Americans in 2025-20. These ACA-compliant plans often include employer-subsidized premiums, reducing costs. Employees eligible for PTC should compare ESI to marketplace plans for cost-effectiveness, 20. Use healthcare.gov's employer coverage tool to assess if your ESI meets affordability standards, e.g., premiums under 9.5% of income, for PTC eligibility. Qualified Small Employer Health Reimbursement Arrangements, CERAs for businesses with fewer than 50 full-time equivalent employees not offering group plans. CERAs allow tax-free reimbursement of individual private insurance premiums or qualified medical expenses. 42. In 2025, maximum reimbursements are $6,350 for self-only coverage, $529.17 per month, and $12,800 for family coverage, $1,066.67 per month. 43, 44. Employees must have minimum essential coverage, e.g., marketplace or off-exchange plans. CERAs are used by 200,000 workers in 2025, per Doyle estimates. Pros: tax advantages, employee plan choice. Cons: requires employer setup, and owners, e.g., S-corp shareholders, may face eligibility restrictions. 45. Platforms like Take Command assist with administration. 42, 43, 44, 45. COBRA continuation coverage under the Consolidated Omnibus Budget Reconciliation Act. COBRA, eligible employees, spouses, and dependents can continue their employer-sponsored health insurance after qualifying events like voluntary or involuntary job loss, reduced hours, divorce, or aging out of a parent's plan, e.g., turning 26, 59, 60. Available through employers with 20-plus employees, COBRA provides temporary, ACA-compliant coverage, covering 4 million people annually in 2025, 61. In 20 states, mini-COBRA laws extend similar benefits to firms with 2 to 19 employees, with varying durations, e.g., 36 months in California's CalCOBRA, 60. Eligibility and enrollment. Qualifying events trigger a 60-day election period to enroll, with coverage retroactive to the event date if premiums are paid. Coverage lasts 18 months, job loss/reduced hours, 29 months, disability, or 36 months, divorce/death, 59. Confirm your qualifying event with HR, as eligibility is event-specific. Costs. Enrollees pay the full premium, employee plus employer share, plus a 2% admin fee, typically $500 to $2,000 per month for individuals or $1,500 to $5,000 for families, without federal subsidies, PTCs/CSRs, 61. For example, a $1,000 per month COBRA plan may cost more than a Marketplace Silver plan at $100 per month with PTCs for a single earner at 138% FPL. Employer severance packages may subsidize costs temporarily. Benefits: maintains the same plan, providers, and EHBs, ensuring continuity for those mid-treatment. Pros: no network or benefit changes, ideal for short-term transitions or high medical needs. Cons: high costs, time-limited, and administrative complexity, e.g., timely election. Compare to marketplace plans during a 60-day SEP triggered by COBRA eligibility, or use COBRA as a bridge to open enrollment for subsidized options like BHP or marketplace plans. 59, 60, 61. Medicare and HSA interaction. For those nearing Medicare eligibility, e.g., age 65 or disability, COBRA can coordinate with Medicare, but enrolling in any part of Medicare, Part A, B, C, or D, disqualifies you from contributing to a health savings account, HSA. This is a common and costly mistake, as continuing HSA contributions after Medicare enrollment can result in IRS penalties, e.g., 6% excise tax on excess contributions. You can still use existing HSA funds for qualified medical expenses, but stop contributions upon Medicare enrollment. Consult Medicare.gov or a tax advisor for guidance, and check with your employer's HR, DOL.gov, or NAIC.org for state mini-COBRA details. 62. State-sponsored guaranteed issue risk pool plans in approximately 10 states, e.g., Maine, Mississippi. As of 2025, legacy high-risk pool programs provide coverage for individuals with pre-existing conditions denied by standard private insurers. 46, 47. These plans offer ACA-like protections, covering EHBs with no waiting periods, often subsidized by insurer assessments. Premiums range from $500 to $1,200 per month for individuals. Pros: safety net for high-risk individuals. Cons: high premiums, limited state availability, and potential enrollment caps. 48, 49. Contact your state's insurance department, e.g., dir.ca.gov for California, or check naic.org. 46, 47, 48, 49. Direct Primary Care, DPC, memberships not insurance. DPC is a subscription model where patients pay a flat monthly fee, $50 to $150 per person in 2025, to a primary care provider for unlimited routine care, e.g., checkups, labs, without insurance billing. 50, 51. Fees are HSA eligible under the 2025 One Big Beautiful Bill Act. 52. Over 1,600 practices operate nationwide, especially in Texas and Oklahoma. Pros: predictable costs, better access, HSA eligible. Cons: no coverage for hospitalizations or specialists, pair with catastrophic plans. Find providers via DPC Frontier. 50, 51, 52, 53, 54. Alternative: Medicaid and CHIP for low-income individuals. If your income is below certain thresholds, you may qualify for Medicaid instead of private insurance. Eligibility and MAGI. Medicaid and Marketplace eligibility are determined by Modified Adjusted Gross Income, MAGI, including adjusted gross income plus certain non-tax sources. Medicaid expansion. In 41 states, including D.C., non-elderly adults qualify up to 138% FPL, e.g., $20,783 for a single person in 2025. The coverage gap. In 10 non-expansion states, restrictive eligibility leaves those below 100% FPL without PTCs or Medicaid in a coverage gap. CHIP covers children at higher incomes, 200% to 300% FPL in many states. Applications are accepted year-round. 20, 21, 22. Part 2, Strategies for Reducing Total Healthcare Costs. Cost reduction involves lowering monthly premiums and minimizing expenses incurred when accessing medical care. Table 1 compares estimated average premiums and deductibles across ACA Marketplace plan tiers to guide plan selection. A. Reducing premiums and cost sharing. Strategy. Mechanism. Benefit. Plan metal level choice. Higher premium plans, Gold/Platinum, result in lower out-of-pocket costs, while lower premium plans, Bronze/HDHPs, have higher deductibles. 9. Choose a high-deductible health plan, HDHP, for lower premiums if generally healthy, or a higher premium plan if frequent care is needed. 9. Utilize value-based networks. Plans with limited or tiered provider networks steer enrollees toward lower-cost providers, often Tier 1, for reduced cost sharing. 8. Reduced premiums and copays, lowers the insurer's cost, which is passed on to the consumer. 8. Emerging value-based care models reward providers for outcomes, potentially lowering overall costs. Maximize tax-advantaged savings. Enroll in an HDHP to qualify for a health savings account, HSA. 15. Use flexible spending accounts, FSAs, individual coverage HRAs, ICHRAs, or XIRAs for tax-free medical expenses or premium reimbursements. 23, 42. HSA Triple Tax Advantage. Contributions are pre-tax/tax deductible, funds grow tax-free, and withdrawals for medical expenses are tax-free. FSAs, ICHRAs, and XIRAs provide additional tax savings, 15, 23, 42. (2025) Tax-advantaged account limits. The following limits apply to the 2025 tax year for optimizing health-related savings. Account type. Maximum contribution. HDHP minimum deductible. HDHP maximum out-of-pocket. HSA, self-only. $4,300. $1,650. $8,300. HSA, family. $8,550. $3,300. $16,600. HSA catch-up, age 55 plus. Plus $1,000 must be in separate HSA for each spouse. Not applicable. Not applicable. Health FSA, employee. $3,300. Not applicable. Not applicable. ICHRAs. Employer determined. Not applicable. Not applicable. XIRAs. $6,350, self-only, $12,800, family. Not applicable. Not applicable. Table 1, 2025 ACA Marketplace Plans, Premiums versus Deductibles. The following table shows estimated average monthly premiums and annual deductibles for a single individual across ACA Marketplace plan tiers for 2025. Actual costs vary by state and plan. Check healthcare.gov for specific plan details. 18. Plan tier. Average monthly premium, $. Average annual deductible, $. Catastrophic. 200. 9,000. Bronze. 350. 6,500. Silver. 450. 4,500. Gold. 550. 1,500. Platinum. 650. 500. B. Minimizing out-of-pocket expenses. Stay in-network. You pay less to see providers who are in-network because they have contracted with your health plan to charge lower rates. Verify provider participation, as narrow networks, e.g., HMOs, EPOs, may limit choices. The No Surprises Act, 2022, protects against surprise billing in emergencies and certain settings. 9/16, such as out-of-network emergency care, air ambulance services, or non-emergency care from out-of-network providers at in-network facilities, e.g., an anesthesiologist during surgery. Choose appropriate care settings. Use an urgent care center or telehealth instead of the emergency department, ED, for non-life-threatening issues to save substantial time and money. Many ACA plans offer $0 copay telehealth for primary care or mental health visits, though coverage varies by plan and state. Check plan details. 9/16. Telehealth has grown significantly in 2025, with expanded coverage for virtual visits, remote monitoring, and behavioral health, reducing barriers for rural or busy individuals. Opt for generic drugs. Ask your healthcare provider if you can switch to generic medications, which have the same active ingredients but cost substantially less. 9. Utilize preventive care. Routine health screenings, vaccinations, and annual wellness visits are typically covered at 100% with no copay or coinsurance under the ACA. 9. Understand FSA rules. A general-purpose FSA is subject to the use it or lose it rule, with unused funds potentially forfeited unless the employer offers a carryover, up to $660 for 2025, or a grace period. Pairing HSA and LPFSA, individuals with an HDHP can use a limited purpose FSA, LPFSA, restricted to vision and dental expenses, to maximize pre-tax savings without compromising HSA eligibility. Part 3. The risks of limited benefit and supplemental plans. Limited benefit and supplemental plans are non-ACA compliant insurance products often sold outside the marketplace. They offer lower premiums but come with high financial risk, as they do not provide the protections of major medical insurance. 3.5. These plans are typically marketed as affordable add-ons to comprehensive coverage or as standalone options for specific risks, but they are not substitutes for ACA compliant plans. ACA Compliance and Minimum Essential Coverage, MEC. All qualified health plans, QHPs, sold on and off the marketplace must meet the standard of Minimum Essential Coverage, MEC. MEC status means the plan covers the 10 essential health benefits, EHBs, e.g., maternity care, mental health, prescription drugs. Achieves a minimum actuarial value, AV, ensuring the plan pays a percentage of the average cost of covered benefits for a standard population, e.g., bronze is almost equal to 60% AV, silver is almost equal to 70% AV, gold is almost equal to 80% AV, platinum is almost equal to 90% AV. Limited benefit and supplemental plans are considered non-MEC because they do not meet these requirements, which is why they carry higher financial risk, as detailed below. Feature: ACA-compliant major medical plans. Limited benefit/supplemental plans. Essential health benefits, EHBs. Must cover all 10 EHBs, e.g., mental health, maternity, prescription drugs. 3.5. Can exclude key benefits like prescription drugs, maternity, and mental health services. 3. Pre-existing conditions. Must cover immediately with no waiting period, guaranteed issue. 3. Can deny coverage or exclude pre-existing conditions from coverage. 3.30. Coverage caps. Has a maximum annual out-of-pocket limit on all covered EHBs. 3. Can impose annual or lifetime dollar limits on payouts, exposing the consumer to massive bills. 3.30. Guaranteed renewability. Guaranteed renewable at the policyholder's option. 5. Not guaranteed renewable, a sick policyholder may be denied renewal. 3.30. Goal. Comprehensive, long-term health coverage. 3. Temporary gap coverage or supplemental coverage for specific risks. 5.30. Limited benefit plan types. Short-term, limited duration, STLD, plans. These plans, regulated primarily by states, vary significantly in availability and terms. A 2024 federal rule limited STLD plans to an initial term of 3 months, with a maximum of 4 months including renewals, effective for plans starting September 1, 2024. However, as of October 2025, federal agencies have suspended enforcement of these restrictions amid ongoing reconsideration and legal challenges, e.g., lawsuits by groups like NAMI against the rule for inadequate protections, allowing insurers more flexibility to offer longer durations temporarily in compliant states. 24-25. State regulations differ. Some states, e.g., Texas, Florida, allow initial terms up to 364 days, with renewals up to 36 months, while others, e.g., California, New York, ban or heavily restrict STLD plans. 25-26. Check your state insurance department for current status, as legal outcomes could alter enforcement. STLD plans lack ACA protections and are best for short gaps in coverage. 24-25. Fixed indemnity plans. Pay a preset, fixed cash amount directly to the policyholder or provider for a specific event, e.g., $100 for an office visit, regardless of the total bill, leaving the consumer responsible for the difference. 5. Health sharing plans. These non-insurance plans involve members pooling funds to cover medical expenses, often through faith-based or community organizations, e.g., MediShare, Liberty Health Share, or Christian healthcare ministries. They lack ACA protections, e.g., no guaranteed coverage for pre-existing conditions, may have lifetime/annual caps, and are not eligible for PTCs or CSRs. They carry significant financial risk despite lower monthly costs. 2. Other limited benefit and supplemental plans. In addition to the above, several other types of limited benefit and supplemental plans are available, often sold through insurers, brokers, or associations. These plans, classified as accepted benefits under the ACA, provide targeted financial protection for specific medical events but are not comprehensive and do not qualify as MEC 30, 31, 32. They can be purchased year-round and are often used to supplement high-deductible plans or cover gaps in other coverage, but they carry risks like low benefit caps and pre-existing condition exclusions. 30, 34. Always verify plan details with your state insurance department, as availability varies and some states, e.g., New York, California, impose restrictions. 37. These plans include critical illness insurance, pays a lump sum cash benefit, e.g., $10,000 to $50,000, upon diagnosis of a serious condition like cancer, heart attack, or stroke. Funds can be used for any purpose, such as treatments, deductibles, or non-medical expenses. Premiums are low, often under $50 per month, but coverage excludes routine care and pre-existing conditions. Best for those with high-deductible plans seeking protection against major illnesses. 30, 31. Accident-only insurance, provides fixed cash payouts, e.g., $100 for an ER visit, $5,000 for a fracture, for injuries from accidents. It helps cover medical bills, lost income, or transportation costs but excludes illnesses, pre-existing conditions, or intentional injuries. Often paired with other coverage for gap protection. 31, 34. Hospital indemnity insurance, offers daily or per visit cash benefits, e.g., $100 to $500 per day, for hospital stays, surgeries, or admissions, regardless of other insurance. It helps offset deductibles, co-pays, or lost wages but does not cover outpatient care or physician fees. Useful for those anticipating hospital stays. 30, 32, 38. Disease-specific plans, e.g., cancer-only insurance targets expenses for a specific condition, such as cancer treatments or chemotherapy. Pays fixed amounts for diagnostics, surgery, or follow-up care but excludes other health issues. Suitable for those with family history or high risk of specific diseases. 6, 31. Accidental death and dismemberment, AD&D, insurance, pays a lump sum for death or severe injury, e.g., loss of limb, from accidents. It's inexpensive but highly restrictive, often bundled with accident-only plans. Not a substitute for comprehensive coverage. 31. These plans are not substitutes for ACA-compliant insurance and may leave significant coverage gaps. They often cap benefits at low amounts that don't match real medical costs, exclude pre-existing conditions, and lack renewability guarantees. 30, 34, 38. While the ACA's individual mandate penalty is currently $0, using these as primary coverage may still pose financial risks. 38. Consult a licensed broker and check state regulations before purchasing, as some plans may be marketed misleadingly as comprehensive coverage. 10. Emerging trends in 2025. Telehealth expansion. Many plans now cover virtual visits at low or no cost, including for mental health and chronic condition management. This reduces travel and wait times, especially in underserved areas. Check your plan's telehealth benefits via the insurer's app or portal. Value-based care. increasing focus on outcome-based payments to providers, which can lower costs through preventive care and coordinated services. Look for plans with value-based networks for potential savings. References.